Good evening, all. Good evening, all. Today, I want to share few things about the pulmonary edema in a pregnant patients. Okay, pulmonary edema from the normal patients to the pregnant patients is entirely different because in pregnant patients, so many physiological changes that will occur that will push the patient into the pulmonary edema stage. So they are more prone for the more prone than the normal patients due to the changes in their physiological changes. Now, a lot of physiological changes will be there. We will discuss in a future slides. So briefly, what is a pulmonary edema? So pulmonary edema refers to an excessive accumulation of fluid in the pulmonary interstitial and alveolar spaces due to the cardiogenic or non-cardiac. Reasons may be the cardiogenic or non-cardiac. These are all the alveoli. Alveoli, they must be filled with the air only. Then only the gas exchange will occur. The oxygen will be taken by the capillaries and carbon dioxide will be released through this. So whenever there is a fluid accumulation in the interstitium or in the air spaces, that is called a condition of pulmonary edema. So this is the normal alveoli. So air will come and oxygen in the air will be taken by the capillaries, the red blood cells, and carbon dioxide will be released. This is a normal phenomena. Ventilation. This is a ventilation. This is a perfusion. So ventilation, perfusion, both are important, especially for the living patients. So whenever you describe any fluid shift in the human body, you have to think of the Starling's equation. This Starling's equation explains what are the forces that may lead to the fluid shift from one intravascular to the extravascular space. So the Starling equation states that transcapillary fluid filtration rate is directly proportional to Kf, that is ultrafiltration coefficient, that indicates the capillary permeability. PMV, that is a microvascular pressure, which is approximately arterial pressure minus venous pressure. And PT, that is a tissue hydrostatic pressure. That's PMV and PT, that is a hydrostatic pressure of the microvascular minus hydrostatic pressure of the tissue minus colloid osmotic pressure of the microvascular space minus colloid osmotic pressure of the tissue. So briefly, three forces are three important factors that will determine this capillary permeability and the increasing the fluid shift from the intravascular to the extravascular space. What are they? They are hydrostatic pressure and colloid osmotic pressure and capillary permeability. These are all the three things. They determine the amount of fluid within the pulmonary interstitium. They are described with the Starling's equation. So this is a briefly anatomy of the alveolus. So this is the alveoli. This is a capillary membrane. This is a capillary space, capillary vessel space. This is the interstitium here. This is the alveoli. Okay, you can see the capillary endothelium is there. This is alveolar endothelium in the form of the type 1 pneumocytes and the type 2 pneumocytes. And this interstitial space, this is a negative pressure space, and this is a capillary space. Whenever there is hydrostatic pressure rises. So for example, if the 12 to 18 mm of HCM, the pressure rises in the capillary, what happens? The vascular congestion. So vascular expansion will be there. Vascular congestion will occur. If the pressure rises to the 18 to 24 mm of HG, the fluid shift from the intravascular space to the interstitial space. Usually the fluid will be drained by the lymphatic drainage. If any obstruction in lymphatic drainage or if any further increase in the intravascular space, there is more than 25 mm of HG, that percent increase the interstitial space and the fluid will be shifted from the interstitial space to the alveolar space. Okay, these are all the three things. So briefly describe what are the different reasons for the pulmonary edema. So increase in intravascular hydrostatic pressure, that is transmitted in a retrograde fashion to the pulmonary vasculature. That is the main important thing that will cause the pulmonary edema. Second thing is increase in interstitial hydrostatic pressure. Here interstitial hydrostatic pressure increases, that will lead to the pulmonary edema to the patients. And endothelial injury and disruption of endothelial barriers, that increases capillary permeability. If any endothelial rupture, endothelial membranes disruption that will give the fluid, the way to the fluid from shifting to the intravascular to the interstitial to the alveolus. And decreasing oncotic pressure, there are so many conditions, that is hepatic condition, renal condition, malnutrition, wherever the protein losses will be there, hypoproteinemia condition. There also the oncotic pressure will affect the fluid shift will occur. And lymphatic insufficiency, the fluid from the capillaries that will go to the interstitial space, that will be drained by the lymphatic drainage. Whenever there is lymphatic insufficiency, the interstitial space pressure will be increases. The fluid will go from interstitial to the alveolus, and increasing the negative interstitial space. Some other condition, the in a space, negative space will be increased in the interstitium. The fluid will be drawn from the intravascular, the interstitial space, and from the interstitial space to the alveolus. So briefly, increasing pressure or cooling, increase the pulmonary vascular pressures, increase the pulmonary capillary pressure, and fluid in the interstitial space first, followed by the increase the pressure interstitial space, followed by the fluid into the alveolus. Finally, the patient may land into the pulmonary edema. So, what are the different conditions in normal adult patients? What are that affects the all five conditions? That is increase the capillary permeability, usually in infections like ARDS and oxygen toxicity, and inhaled and circulated toxins. There, the capillary permeability, the membrane will be damaged. Endothelial membrane will damage, the capillary permeability increase. And increased capillary hydrostatic pressure may be seen in the increased left atrial pressure resulting from the left ventricular failure or mitral stenosis, and over administration of the intravenous fluids, that it itself it increases the capillary hydrostatic pressure, and plethora resulting from the renal insufficiency, that is also fluid shift occurs, and pulmonary vena occlusion disorders that increase the pressure, back pressure, that will increase the pressure in the pulmonary vasculature, and post-obstructive pulmonary edema, that is negative pressure pulmonary edema. In these conditions, the increased capillary hydrostatic pressure will occur. And decreased interstitial hydrostatic pressure, that too rapid evacuation such as pneumothorax and hemothorax, that is called re-expansion pulmonary edema. In that condition also, the patient may land into the pulmonary edema. And decrease the colloid osmotic pressure, already discussed, there is the protein starvation and dilution of proteins by the intravenous solutions, and renal problems resulting in the urinary protein loss causing the hypoproteinemia. They will affect the oncotic pressure, and they hasten the pulmonary edema. And lymphatic, finally, the lymphatic obstruction, that is insufficiency of pulmonary lymphatic damage. It's called lymphatic carcinoma. These are all the normal conditions that occurs normal adult patients. Let us see what are the different conditions in pregnant patients. What are different reasons? So, what are the risk factors for the development of acute pulmonary edema in a pregnant patient? One is a cardiovascular disease. That is the pre-existing pre-pregnancy conditions, and specific disease of the pregnancy, and pharmacological agents, and iatrogenic fluid therapy, and fetal condition. These are all the different conditions. Cardiovascular disease like hypertension, ischemic heart disease, congenital heart disease, and valvular heart disease, and arrhythmias and cardiomyopathy condition. The patient may go into the risk in the pulmonary edema, and obesity patient increase in maternal age, and some endocrine disorder that will increase the blood pressure, especially the pheochromocytoma and hyperthyroidism. The patient may land into the pulmonary edema very easily. What are the specific diseases of the pregnancy that they push the patient into the pulmonary edema? Preeclampsia, cardiomyopathy, and sepsis, and preterm labor, and amniotic fluid embolism, and pulmonary embolism. These are all the specific diseases of the pregnancy. In that situations, the patient may land into the acute pulmonary edema. What are the pharmacological agents used in the pregnancy that will lead to pulmonary edema? Beta adrenergic tocolytic agents, they will use for the uterine relaxation, and some corticosteroids, and rapid infusion of the magnesium sulfate, and along with the magnesium sulfate, so intravascular fluids should be very cautious, and illicit drugs like cocaine, it causes hypertension, and iatrogenic intravenous fluid therapy, that is a positive fluid balance of more than 2000 ml, and fetal conditions like multiple gestation. In all these conditions, the patient may prone for the acute pulmonary edema in a pregnant patients. So, incidence of pulmonary edema in pregnant patients that ranges from the 0.08 to the 0.5%. The most common attributable cause are the pre-existing cardiac disease, that is 25.5% of all cases. Tocolytic cues are 25.5%. And there's a 50%, you can see that cardiac disease and tocolytic disease. Remaining conditions like iatrogenic fluid overload, usually we will see in enthusiastic clinicians, that leads to 21.5%. The pregnant patients, especially patients are in a preeclampsia and eclampsia patient, the fluid overload, then rapidly they will go into the acute pulmonary edema. And preeclampsia, in 18% of the patient preeclampsia. In preeclampsia patient, 30% develop in the antenatal period and 70% develop in the postnatal period. And the acute pulmonary edema in pregnancy, they broadly divide into the two scenarios. One is acute pulmonary edema without hypertension or normotensive or hypotensive. Patient with a normotensive or hypotensive, patient may develop the acute pulmonary edema. Second scenario is acute pulmonary edema, patient with a hypertension. So because pathophysiology is entirely different and management also entirely different. That's why they broadly divide into this acute pulmonary edema in pregnancy into the two categories. So what are the different conditions that will affect the cardiac function in healthy pregnant patients are the effect of circulating hormones in a pregnancy and mechanical pressure of the enlarging uteroplacenta fetal unit and increasing the metabolic demands of the uteroplacenta fetal unit and the presence of uteroplacental circulation and labor imposes actual cardiovascular stress due to uterine contractions, pain and positioning, bleeding and fatigue and uterine involution. So postpartum fluid shift, the autotransfusion, hormonal changes further alters the cardiovascular system, cardiovascular function. So these are all the conditions that will alter the cardiovascular function, especially in a healthy pregnant patients. So compared to the non-pregnant patient, healthy pregnant patient, these are all physiological changes. That is the increased cardiac output, increased heart rate, increased blood volume, the physiological anemia, and decreased systemic vascularization, decreased blood pressure. And healthy pregnancy patients are associated with low colloid osmotic pressure to the left ventricular and diastolic pressure gradient, thereby predisposing even healthy pregnant woman to the risk of acute pulmonary edema. Now, all the conditions increase cardiac output and increase heart rate, increase blood volume, and low colloid osmotic pressure. These are all the four important factors that will push the patient, healthy pregnant patient, into the acute pulmonary edema state. So some compensation will occur in healthy pregnant patients, but the compensation for the physiological and pathological change of pregnancy depends upon the three important factors. That is her underlying cardiovascular reserve that depends upon the cardio. If the cardiovascular reserve is very less, the patient may go into the acute pulmonary edema. Or if cardiac function is good, it's okay. If cardiac function is affected, that will also patient. And the extent of the disease, but now if there is any cardiac disease and other conditions, the three things they will important factors. So whenever the acute pulmonary edema without hypertension, that is a normotensive hypertension patient, what are the common associated factors are? The thrombolysis, sepsis, and pre-existing cardiac disease, pregnancy associated cardiac disease, cardiomyopathy, and ischemic heart disease, and amniotic fluid embolism with left ventricular systolic failure, and aspiration and iatrogenic intravenous fluid admission. In all the conditions, patient may present with the acute pulmonary edema, but pressures are normal or low. So, pathophysiology of the acute pulmonary edema with the normotensive is mainly the alteration in the forces that is the controlling the pulmonary interstitial fluid, that is hydrostatic pressure, colloid osmotic pressure, and capillary permeability that occurring in non-pregnant adults. So, main thing is iatrogenic causes. So, iatrogenic causes remain important factors acute pulmonary edema without hypertension. So, the management of preterm labor with a tocolytic agent, especially beta agonist, has been associated with acute pulmonary edema. So, important mechanism in this setting includes the beta adrenergic receptors. They will affect on the capillary permeability. They will increase capillary permeability and they will reduce the myocardial contractility. Along with the fluid administration during tocolytic therapy and the concurrent use of steroids, patients may go into the acute pulmonary edema. And magnesium sulfate and corticosteroids, they are implicated as a pulmonary edema in pregnant patients. So, women in whom magnesium sulfate infusions are administered for the fetal neuroproduction in the preterm labor need to be carefully monitored and their fluid vitals meticulously recorded. That is a level 2 evidence. We should be carefully monitored and meticulously recorded the fluid status whenever the patients are receiving the magnesium sulfate infusions. So, acute pulmonary edema with hypertension patients, approximately 15% of pregnant women, they will suffer with the acute pulmonary edema with hypertension. So, any form of sustained hypertension, that is systolic more than 140, diastolic more than 90% in pregnancy is abnormal. As a healthy physiological response to pregnancy is a reduction of blood pressure. Usually, in pregnant patients, the blood pressure reduces. But if the blood pressure is 140/90, you can diagnose as a hypertension. So, in addition to the chronic hypertension, gestational hypertension, preeclampsia superimposed chronic hypertension, they are the risk factors. So, other factors are Remember, women with a critical high blood pressure after using illicit drugs like cocaine, if they have an underlying endocrine disorder, that is hyperthyroidism, pheochromocytoma, hypertension will be the present, then the patient may land into the pulmonary edema conditions. So this pulmonary edema makes approximately 3% of women with a preeclampsia and 70% of the cases occurring after birth. Mainly the reason of autotransfusion may be the reason. And it is also associated with the HELP syndrome, that is the hemolysis and liver enzymes and low platelet counts and eclampsia. In these conditions also the acute pulmonary edema with hypertension occurs. So what are the cardiac abnormalities in women with preeclampsia? They may lead to the acute pulmonary edema. So cardiac increased cardiac output, mildly elevated in systemic vascular resistance, and low cardiac output with elevated systemic vascular resistance and diastolic dysfunction, and increased left ventricular mass and pericardial effusion. These are all the important cardiac abnormalities. We can see the preeclampsia. They will push the patient into the acute pulmonary edema. So this is important cycle. The pressure volume loops. The black indicates the normal patients. So green indicates the healthy pregnant patients. Red indicates the preeclampsia patient. What happens? This is the diastolic curve increase. So in preeclampsia, so in healthy pregnant, there is upward displacement of diastolic resting tension curve. This is a diastolic resting tension curve. This will be upward displacement in the normal healthy patient and downward displacement of the systolic curve. It will be seen. So mean arterial pressure will be decreased. This is a mean arterial pressure. This is a normal mean arterial pressure. The curve will be decreased here. In preeclampsia, there is further upward displacement of the diastolic curve. Here you can see the further upwardment of the diastolic curve. That is the same left ventricular end-diastolic volume is associated with the increased left ventricular end-diastolic pressures will be raised. So the systolic curve may shift to the upwards and downwards in a preeclamptic patient, but the mean arterial pressure curve will be upwards. So mean arterial pressure will be increased. The mean arterial pressure will be increased healthy pregnant women. So the location of the pressure volume in the diastolic curve may alter with the gestation. There is no consistent agreement healthy pregnant or woman or the preeclampsia. So preeclampsia along with the pressures of the cardiac status, it also affects on the plasma colloid oncotic pressure. The plasma colloid oncotic pressure will be decreases. So and it alters the endothelial permeability. They are very sensitive to the fluid shifts, especially preeclampsia patients. And reduction the colloid oncotic pressures, osmotic pressures to the left ventricular end-diastolic pressure gradient. They are all the three things the patient may lead to the pulmonary edema in a preeclampsia patients. So along with that, the acute hypertensive case that precipitates the acute pulmonary edema occurs through the sympathetic nervous system activation. Whenever the sympathetic nervous system activation occurs, they cause the acute venoconstriction, vasoconstriction. This will lead to the increased afterload and redistribution of fluid from the peripheral circulation of the pulmonary vessels. The pulmonary vascular pressure will be increases. This causes the alveolar fluid accumulation and reduce oxygenation concurrently, increase the cardiac output as a compensatory mechanism as a reduced renal oxygen delivery. So this is very important slide. It shows unrestricted intravenous fluid therapy is a recognized significant risk factor for development of acute pulmonary edema. That level 3 evidence. The use of intravenous fluids was thought to improve the maternal cardiovascular parameters. However, one large trial gives the level 1 evidence and systemic to the level 2 evidence. Volume expansion was not beneficial in these conditions. Moreover, the intravenous fluid therapy may also exacerbate the acute respiratory distress syndrome, leading to the hypoxia and high pressures and difficulty with ventilation. The postpartum period is high risk of the development of acute pulmonary edema if you use the unrestricted intravenous fluids. The use of intravenous fluids to increase the plasma volume due to the oliguria, which is multifactorial in nature in women with a. So that's why in women with a normal renal function and stable serum creatinine levels, the IV fluid administration is not recommended. So whenever there is a normal renal function, stable serum creatinine, you have to give the IV fluids very judicially. That is a level 1 plus evidence. So antenatal fluid therapy may be indicated if there are concerns about the placental perforation. However, the communication with the obstetric team and cautious use should occur. So with close monitoring of cardiovascular and respiratory function must be there whenever you are giving the giving the intravenous fluid therapy in our patients you are suspecting any placental perfusion deficiency. And what are the different strategies to reduce acute pulmonary edema in pregnant patients? So what is the risk reduction strategy? So for that we have to planning and communication and close observation, avoidance of present, early intervention must be there. So risk reduction strategies are multidisciplinary team involvement, obstetrician and anesthetist and intensivists are give the level 3 evidence. And effective verbal and written communication and handover is must present whenever the pulmonary edema pregnant patient, and close monitoring and recording of observation including the conscious state and blood pressure and respiratory rate, heart rate, oxygen saturation, temperature and fluid balance is very must. That gives a level 3 evidence. And we have to do the close monitoring and recording of the biochemical parameters, that is hematological, renal, metabolic and respiratory. We should do. That is a close observation, that will level 3 evidence. And avoidance of precipitates like avoidance of non-steroidal anti-inflammatory drugs that they will causes the fluid retention. That is the level 3 evidence. And restricted fluid administration and the minimization of intravenous fluid use, especially when you use the magnesium sulfate and there is a synthogen infusion. They give the level 3 evidence. And early intervention, whenever the patient presents the critical hypertension that is systolic more than 150 requires antihypertensive therapy. When the systolic blood pressure more than 180 is a medical emergency required urgent reduction. That is a 1111 plus evidence. So more than 150, they should start the antihypertensive therapy. And then more than 180, we have to declare as a hypertensive crisis and urgent reduction must be there. So how to diagnose acute pulmonary edema in pregnant patients? By the clinical symptoms and signs. What are the symptoms? The patient may complain of breathlessness, orthopnea, agitation, cough, and will be very anxious and anxious patient. And clinical signs are tachycardia, tachypnea, and you can see the crackles or wheeze or chest auscultation, and cardiac S3 gallop of the mill present, and so you can see the murmurs also sometimes, and decreased oxygen saturation. Typical chest X-ray includes upper lobe redistribution of Kerley B lines and pulmonary filters you can see, and ABG decreased pulmonary decreased PaO2, and ECG echocardiography may help the establishment of the diagnosis of acute pulmonary edema conditions, and transthoracic echocardiography is the key of diagnostic and management tool. So management of hypertensive acute pulmonary edema pregnancy goals are reduce the left ventricular preload, reduce the left ventricular afterload, and reduce and prevent the myocardial ischemia, and maintain the adequate oxygenation and ventilation, the clearance of pulmonary edema. So this is the algorithm that shows how to react whenever the acute pulmonary edema occurs in a pregnant patient. First thing is it's an emergency condition. We have to call for help and skill assistance. First, you have to take care of the airway, clear obstruction if present. Patient, you have to keep the patient upright position and you have to administer the oxygen. Next, you have to assess the breathing, the respiratory rate and oxygen saturation and temperature, and how to take fast. You have to take the chest X-ray and ABG. You have to auscultate the chest, and you have to consider the non-invasive or invasive ventilation according to the patient situation. So circulation, you have to minimize aortic valve compression. So maternal, you have to assess the blood pressure and heart rate and rhythm, disease and fluid balance. And fetal, you have to heart rate and gestations. IV access, full blood examination, assess the renal function, liver function, assess the coagulation, cardiac enzymes, and transthoracic echocardiography, continuous monitoring. You have to see the airway and breathing and circulation. Then you have to go for the blood pressure. If the patient is hypertensive, what are the probable conditions? Preeclampsia, endocrine disorder, illicit drugs, cocaine, IV fluids, and other conditions. The patient is hypertensive, you have to administer the drugs like NTG and furosemide and morphine. Along with that, we can take the help of magnesium sulfate. If the blood pressure is not controlled with the magnesium sulfate, also go for the calcium antagonist. If the patient is normotensive or hypotensive, so consider the cause of cardiac disease and sepsis and tuberculosis, amyloid fluid embolism, aspiration, intravenous fluids, and other conditions. In the conditions, we have to give the furosemide along with the furosemide acts as a vasodilator. You have to take the help of the inotropic support also. So we have to maintain the blood pressure and we have to take the mechanical support if the patient condition deteriorating. So we have to stabilize the patient and plan the safe birth and transfer the patient after delivery to the intensive care environment. So NIV is important thing whenever the patient is landed the acute pulmonary edema, especially pregnant patient. It provides the increased inspired oxygen concentration. It helps to displace the fluid from the alveoli into the pulmonary, and it helps subsequent systemic circulation, and it helps to decrease the work of breathing, and it helps to decrease the need for the tracheal intubation. So the use of NIV also avoid the complications with the tracheal intubation, especially in pregnant patients. And recently, pregnant patients who are hypertensive, sometimes may go into the intracerebral hemorrhage during intubation. So mechanical ventilation strategies when ventilating the lungs in a pregnant or recent pregnant woman, as well as the lung protective strategy, there is a low tidal volumes, low peak pressures, we have to say, and always avoidance of aortic cable compression is essential along with the NIV. Circulation, urgent reduction the critical high blood pressure intravenous antihypertension is necessary. Nitroglycerin is recommended, is a drug of choice in preeclampsia with the pulmonary edema level 3 evidence. So nitroglycerin in NTG, it is infusion starting at the 5 micrograms per minute, gradually increase every 3 to 5 minutes with a maximum dose of 100 mics per minute. So nitro NTG can also be administered by sublingual spray, that is a 4 mic spray, 1 to 2 puffs every 5 to 10 minutes. Alternatives are sodium nitroprusside and other antihypertensive drugs. So reduction of systolic and diastolic blood pressure should occur at the rate of 30 mm of Hg over 3 to 5 minutes. But you have to reduce the blood pressure very slowly, and slow reduction of blood pressure to approximately 140/90 your target blood pressure. So intravenous furosemide, we have to give the bolus of 20 to 40 milligrams over 2 minutes. That is used to promote the venodilation diuresis. The repeated doses, that is 40 to 60 milligrams after approximately 30 minutes if there is no inadequate diuretic response. So maximum dose is 120 milligrams per hour. This is a level 1 evidence. So hypertension persists despite the combination of NTG and sodium nitrate and furosemide. You can take the help of the calcium channel antagonists such as nifedipine and nicardipine. They may be considered. And prazosin also considered. Intravenous morphine 2 to 3 milligrams may also be given. It acts as a venodilator and angiodilator, especially in the acute pulmonary edema in pregnant patients. So planning and communication, it should be multidisciplinary team management. So we can involve the obstetrician and anesthesia and intensivists. So patient should be taken care of the high dependency care and close monitoring the 1-to-1 nursery. Level 3 evidence, continuous monitoring of vital signs and serial monitoring of respiration, cardiac and renal hematological function, assessment of fetal well-being and multidisciplinary planning of safe birth if acute pulmonary edema occurs in antenatally. Strict fluid balance and fluid restriction should be you have to maintain, and control the blood pressure to the 140/90 level 1 plus evidence, and prevention of further complications. Eclampsia prophylaxis with the magnesium sulfate if the woman has a pre-eclampsia, and prevention of deep vein thrombosis, that is a pulmonary embolism we have to take care of, and prevention of stress ulceration of the gastrointestinal tract by using the proton pump inhibitors and H2 receptor antagonist. So long-term management, this women who suffer with the severe preeclampsia and experience the acute pulmonary edema increased risk of cardiovascular complications in later life, including the hypertension and ischemic heart disease, stroke and renal disease. So this should be closely monitored the controlled blood pressure until the resolution of initial disease process, and then followed up regularly and observe the long-term complication of the disease. So AC inhibitors, which are contraindicated in pregnancy, they are safe in a postpartum period. We can use it. And risk reduction strategies should be offered, such as weight reduction, smoking cessation program, dietary modification, encouragement of regular exercise, and control hypertension to control the complication for the long-term management. So this is important one algorithm is there. There is a protocol-based management of acute pulmonary edema in pregnancy in a low resource centers. In a low resource center, how to manage the acute pulmonary edema in a pregnant patient. This is important. This whenever the acute pulmonary edema you are suspecting low resource areas, first thing is you have to call for help. First you have to assess the airway. You have to clear the airway, 40 minutes head up position, and oxygen inhalation by the 8 to 10 liters per minute. Followed with the breathing assessment as a respiratory rate and the saturations as you have to monitor, and auscultate the chest, and you have to immediately you have to send for the APGA, and you have to consider the continuous positive airway pressure support. For circulation, we have to assess the heart rate and now we have to measure the BP and secure the IV axis, send for investigations and ECG, and we have to do the Foley's catheterization to monitor the urine output. We have to quickly take the X-ray chest. Here three conditions. One is the pulmonary edema with hypertension, pulmonary with a normotension, pulmonary with hypotension. Whenever the pulmonary with the hypertension, whenever the blood pressure is more than 160 per 100 mm of Hg, we should not give the bolus of IV fluids. You have to maintain the IV fluids as a lifeline. You should not give the bolus of magnesium sulfate. Magnesium sulfate can be considered after resolution of the acute pulmonary edema only. So that to be you have to give the 4 grams infusion over the slow for 30 minutes. And do not give the IV bolus of labetalol. It's a detrimental if the mother has a postpartum cardiomyopathy. So these are all the precautions you have to take whenever the pulmonary edema, the hypertension patients. Reasons are severe preeclampsia, hypertension crisis, and valvular reasons are PPCM and IV fluid overload and pheochroma conditions. So when the patient is hypotension, so what are the reasons? Sepsis and cardiac failure and valve and PPCM and tocolysis used, tocolytics induced or anemia with fluid overload and amniotic fluid embolism and massive pulmonary embolism. So whenever the patient is acute pulmonary edema with hypertension, normotension, you have to go according to the blood pressure. If the patient is pressure is more, then you have to head up position. So you have to give the oxygen with a reservoir bag, 8 to 10 liters per minute. Your aim of saturation is more than 94%. So you have to give the furosemide 40 milligrams IV repeated every 10 to 15 minutes depending upon the blood pressure. And you have to take the help of NTG infusion at the rate of 3.5 ml, that is the per hour, that is a 0.5 microgram per kg per minute. If the SpO2 is less than 94%, we have to take the help of CPAP with a PEEP of 8 centimeters H2O, or we have to take the help of BiPAP, and you have to consider the 3 milligrams IV morphine. If the patient is hypotensive, then you have to consider the intubation or to maintain the saturation. If the patient condition is deteriorating, you have to intubate the patient and go for the early echo to diagnose the condition and take the help of noradrenaline 4.5 ml per hour, that is 0.05 milligrams per kg per minute to maintain the inotropism. And you have to take the, along with the vasopressors, you have to take the help of furosemide 40 milligrams IV after inotrope only you have to give. And you have to give the morphine IV and dexmedetomidine to decrease the angiolisis, to decrease the sympathetic discharge. So you have to take the ventilator support PEEP of 5 to 8 centimeters H2O. So these two conditions followed by the stabilize the mother and consider delivery. The mode of delivery may be the vaginal and LSCS. The vaginal delivery, assisted vaginal delivery with careful oxytocin augmentation if the Bishop score is favorable. If it is not favorable, go for the LSCS by the help of subarachnoid block or incremental epidural or GA with a rapid sequence induction and intubation. So subarachnoid block only if hemodynamic stable patient or normal echo, then only you will go for subarachnoid. Otherwise, you go for incremental epidural or GA with a rapid sequence induction and intubation. And you have to taper the NTG infusion at a 7 centimeters of cervical dilatation during vaginal delivery when taking up of LSCS. You have to take care of. You have to don't allow the patient to go the more hypotensive also. So immediately after delivery of the baby, in both vaginal and LSCS, you have to give the furosemide 40 milligrams. That is the Lasix 40 milligrams and oxytocin infusion. So the auto transfusion occurs after delivery of the baby. To prevent the overload on the heart, to prevent the increase of hydrostatic pressure, you have to give the furosemide 40 milligrams immediately after delivery of the baby head in both vaginal and LSCS. Oxytocin may be 20 units and 20 ml syringe, that 5 ml per hour for 2 hours. And rectal misoprostol 800 to 100 milligrams. If LSCS consider LSCS consider the prophylactic bleeding if you are suspecting any atony of the uterus. For postoperative pain relief, you will go for the epidural analgesia or tab block or fentanyl IV infusion. That is the 1 mg per kg per hour. If IV paracetamol, if liver enzymes are normal. If the patient is intubated for the delivery, for the normal or LSCS, you have to continue the elective ventilation for 12 hours after delivery of the baby with the tidal volumes of 6 to 8 ml per hour, the respiratory rate of 12 per minute and PEEP of 5 to 8 centimeters of H2O. and initial FiO2 may be 1, and you have to decrease the taper the FiO2 after 1 hour according to the condition of the patient. So these 4 things you have to monitor and you have to take consideration in pregnant patient, that is increased preload, that may be the IV fluid administration and fluid redistribution after the placenta removal. That's why we have to give the furosemide here. And cardiac features, especially cardiomyopathy, valvular heart disease, and cardiac diastolic dysfunction, we have to be very careful. And afterload increase condition, that is severe hypertension, that increase the peripheral vascular resistance. So you have to decrease the blood pressure by to decrease the peripheral vascular resistance, to decrease the pulmonary hydrostatic pressures. Others all reduction of, we have to take care of the conditions like reduction of oncotic pressures, and we have to take care of increasing capillary pressure. These are all the 4 important conditions. The take-home message is we have to give the intravenous fluid administration very judiciously, especially when the patients are high-risk patients, especially pre-eclampsia and eclampsia patients. And after delivery of the patient, we have to give the diuretics to counteract the autotransfusion. Okay, so pulmonary edema is a very common, because in pregnant patients, so many physiological changes may occur that will alter the capillary permeability, that will alter the oncotic pressure, that will alter the intravascular pressures also. So you should be very cautious when you are dealing the acute pulmonary edema in a pregnant patients. Moreover, they are if you correct the physiological things, the prognosis will be more, the patients will be recover very fast. Thank you.